Thank you for participating in this quality improvement project and educational session. The focus of this presentation is reducing facility-acquired ulcers in the long-term care setting. This presentation will offer broad education regarding pressure ulcers and specific interventions that are evidence-based and may be used at Pleasant View Center to improve overall quality of care. At the end of this educational session, you will be able to identify the etiology of pressure ulcers, identify correct staging of pressure ulcers, identify pressure ulcer risk, gain knowledge of pressure ulcer prevention, and identify 3 evidence-based practice interventions to implement at Pleasant View Center. A pressure ulcer is defined as damage of skin and underlying tissue, typically over a bony prominence or near a medical device. Pressure ulcers may present as intact skin, including blisters, or may be present as an open ulceration. Pressure injuries are a result of prolonged pressure to a specific area and may involve shearing. Pressure ulcers are classified by the National Injury Advisory Panel through a staging system. Prolonged pressure, shearing, friction, and moisture may influence the development of a pressure ulcer. Some common risks that influence pressure ulcer development in residents include decreased mobility, advanced age, inadequate nutrition or hydration, reduced sensation or comorbidities, such as diabetes, vascular disease, dementia, obesity, or other neurological diseases that affect mobility. Prolonged pressure, shearing, friction, and moisture may influence the development of a pressure ulcer. Some common risks that influence pressure ulcer development in residents include decreased mobility, advanced age, inadequate nutrition or hydration, reduced sensation or comorbidities, such as diabetes, vascular disease, dementia, obesity, or other neurological diseases that affect mobility. A Stage 1 pressure injury consists of intact skin with the presence of non-blanchable erythema. These wounds do not have purple or maroon discoloration, but may present in a light pink to red color. To check for blanching, lightly apply pressure on the skin with your finger, release the pressure, and if the skin turns to a lighter color, then returns to original color, it is blanchable. If the erythema is persistent, the skin is not blanchable and is classified as a Stage 1 pressure ulcer. These wounds are usually managed with protection from further breakdown, such as offloading and skin protectants. A Stage 2 pressure ulcer consists of a partial thickness ulcer with the presence of skin loss that reveals epithelial tissue. A partial thickness wound involves exposure of the epidermis and dermis. This ulcer will present as a shallow open wound revealing epithelial tissue that presents as a pink or pearly white tissue. A Stage 2 pressure ulcer may also be a serious filled blister originating from prolonged pressure. Epithelial tissue is non-vascular, which results in a serous blister, compared to a blister of color that is influenced by vascular tissue. A Stage 2 pressure ulcer does not have presence of granular tissue, slough, or adipose tissue in the wound. These wounds are usually managed with moist wound healing and protection from further breakdown. A Stage 3 pressure ulcer is a full-thickness ulcer in which tissue loss has extended through the dermis into the subcutaneous tissue, revealing granular tissue or fatty tissue. Granular tissue is vascular, therefore sanguineous drainage may be present. These wounds may also have presence of necrotic tissue of slough, or as well as undermining or tunneling. Undermining is the existence of a pocket-like presence under the wound edges, often caused by shearing. Tunneling is a channel-like passage that extends from the wound bed into deeper tissue. Stage 3 pressure ulcers do not have presence of fascia, muscle, tendon, ligament, or cartilage. Management of these wounds commonly involve debridement of necrotic tissue, mitigation of infection, packing the wound bed including undermining or tunneling, and management of exudate. Further intervention for pressure should be prioritized. A Stage 4 pressure ulcer is the most severe type of pressure ulcer that is characterized by full-thickness tissue loss that extends to bone, tendon, or muscle. These wounds often also have presence of undermining or tunneling. Slough or eschar may be present. Treatment of these ulcers may include debridement of necrotic tissue and advanced wound dressings prioritizing moist wound healing and management of drainage. Further pressure relief strategies should be prioritized to prevent further tissue damage and guide healing. Specialists may need to be part of the interdisciplinary care team, such as nutritionists, wound specialists, physical therapists, infection preventionists, and pain specialists. An unstageable pressure ulcer is a full-thickness ulcer in which the base of the wound is obscured by necrotic tissue, making it unable to accurately stage the wound and identify its true depth. Due to the inability to stage the wound, it is classified as an unstageable until the base of the wound can be visualized. At which time, the pressure ulcer will be reclassified to either a Stage 3 or a Stage 4 pressure ulcer. The ulcer can only be reclassified as these 2 pressure ulcer stages due to its full-thickness appearance and presence of slough at some point of its duration. Care management of these wounds include infection prevention, specialty dressings, debridement and routine pressure prevention to avoid deterioration of the wound. A multidisciplinary team approach may be warranted to achieve healing. A deep tissue injury is a type of pressure ulcer that involves intact or non-intact skin with areas of non-blanchable deep red, maroon or purple discoloration or a blood-filled blister. The damaged tissue indicates full-thickness tissue damage. Due to this type of wound may be reclassified if it opens and reveals a wound base. At this time it would be reclassified to a stage 3 or stage 4 pressure ulcer due to its full-thickness injury. Treatment of these wounds are focused on minimizing further injury and promoting healing through repositioning, specialty surfaces, offloading and protection. A multidisciplinary team may also be utilized to optimize outcomes. Now that we have reviewed pressure ulcer risk, etiology, and classification, we can further focus on Pleasant View Center. Pressure ulcers prevalence at Pleasant View Center is 11.1% compared to 5.9% for the state average and 7.8% for the national average. The 11.1% rate is impacting the overall quality score of the center, which is currently a 2 out of 5-star rating per Medicare. During March of 2024, there were 30 pressure ulcers at the facility. 15 of those ulcers were facility acquired. 4 of the pressure ulcers documented in March were facility acquired during the March month alone. Currently at PVC, all patients are evaluated for appropriate pressure redistribution surfaces on admission and regularly by therapy. All patients are set up with a pressure-relieving cushion as well as a memory foam mattress for baseline redistribution of pressure. If a patient has an increased risk or has a pressure ulcer, they are given advanced pressure surfaces to include specialty chair cushions and low air loss mattresses. The center is doing well on this prevention strategy. The center is also doing well with nutritional assessment and risk identification. All patients are evaluated by a nutritionist upon admission and routinely to monitor nutritional risk that could influence pressure ulcer prevention or healing. Areas that PVC should focus on for pressure ulcer interventions include skin checks, moisture management, and repositioning. A complete skin check should be conducted for all patients within 24 hours of admission and weekly. By completing this check, we are able to identify risk of skin breakdown and act immediately to have the opportunity to identify a pressure ulcer early in its development and enhance chance of healing. A quality improvement project has been developed with these focuses to assist PVC in pressure ulcer prevention with the goal of reducing their rates of incidence below the national and stage average. An intervention bundle is a set of evidence-based practices that are combined together to optimize patient outcomes. Intervention bundles were identified as one of the top 4 interventions used to prevent pressure ulcers, especially in complex care patients. The intervention bundle that has been developed to improve quality at Pleasant View Center involves a total of 3 interventions focused on moisture management, repositioning, and offloading. The first intervention of the quality improvement bundle is focused on moisture management, which is crucial to the prevention of skin breakdown. Moisture causes skin vulnerability and can subsequently influence pressure ulcer risk and development. Zinc oxide is an enhanced barrier cream that prevents the skin penetration of bacteria, contact irritants, and allergens. The intervention of apply a zinc-based barrier cream to patients' buttocks and peri-region can protect their skin and reduce vulnerability. This intervention should be implemented for all patients with incontinence. The intervention should be initiated by the nurse on admission or with the development of new incontinence. The intervention should be placed as an order in the patient's chart, added to the patient's plan of care, and communicated with the licensed nursing assistants providing patient care. The nurse or the LNA will cleanse the patient's skin with soap and water, apply a thin layer of zinc barrier cream and repeat the process with all hygiene or incontinence care. The second intervention of the quality bundle is focused on repositioning. Patients with reduced mobility have an increased risk for pressure ulcer development. The nurse should evaluate if a patient is able to change positions independently. If they are unable, this intervention should be ordered and added to their plan of care. All patients who are unable to reposition independently should be turned and repositioned every 2 hours by nursing staff. The nurse or licensed nursing assistant will position the patient optimally to redistribute pressure or fragile skin, encourage use of various positions and utilize positioning wedges or pillows to support the patients or residents. Devices accessible at Pleasant View Center includes pillows and positioning wedges. Pillows should be placed in such a way that reduces pressure from bony prominences and supports the body's position. The heel is one of the 2 most common sites for pressure injuries, and pressure of the heel should be relieved through elevation with a suspension device, pillows, or appropriate offloading device. Several pressure reduction devices have been shown to reduce pressure ulcers of heels, including foam cushion, foam suspension, and suspension boots. This quality intervention involves adding the direction of offloading heels to a patient's orders or plan of care if the patient cannot adjust position independently. This intervention will be completed by the nurse or nursing assistant whenever in-bed care is being provided. The care providers will need to ensure the patient's heels remain offloaded and may require frequent checks and adjustments. The pillow should be placed vertically under the patient's legs from the knees to the ankles to provide offloading of the heels and support of the leg. Placing the pillow horizontally should be avoided as this could cause pressure behind the patient's knee as it would be left unsupported. An intervention bundle of 3 interventions has been identified that will be implemented at Pleasant View Center aimed at pressure ulcer prevention. The success of this quality improvement intervention bundle is reliant upon each and every nurse at the center. It is the duty of the nurse to continue to evaluate all patients for pressure ulcer risk and act immediately. When completing admission or routine skin checks, take note of any presence of skin moisture or decreased mobility. If these are noted, the patient has risk for pressure injuries and the intervention bundle should be ordered. Implement the zinc barrier cream with hygiene care intervention for patients noted with incontinence and implement repositioning every 2 hours and offloading of heels for patients with decreased mobility. After implementing these orders and plan of care adjustments, educate your nursing staff to ensure the interventions are carried out. Nurses are leaders in healthcare. You have the expertise and power to guide your patients and our facility to success. Stay empowered by knowledge. By completing this educational session today, you are taking a step towards safeguarding your residents' health. By addressing pressure ulcer risk and applying interventions into your nursing practice, you are advocating for comfort, dignity, and improved well-being of your residents. Be a leader of pressure ulcer prevention, prioritize your patients' care and safety, and guide your colleagues and nursing assistants towards excellence. Your dedication and commitment will make a tangible difference in the lives of your residents and their families. Lastly, demonstrate the positive change at the center that you want the team to strive for. Your nursing care holds substantial value in the protection of pressure ulcers in your patients. Take pride in your hard work and dedication. Thank you not only for your participation in this educational session, but for your compassion and knowledge that you bring to your career. Advancements in nursing knowledge and resident care would not continue to develop without your participation. Please reach out to Stacy Reese, doctoral nursing student, with any questions you may have regarding this session.